See lots of people in the group, and I'm so glad that you're able to join us and be here for the new tool launch that we're going to go through today. I'd first like to start off by acknowledging that we're gathered here today on Treaty 1 land, home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. And so in coming together today, we respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. We recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems, and we dedicate ourselves to moving forward in partnership in the spirit of reconciliation and collaboration. And in talking about patient and public engagement and health research, Indigenous research methodologies, I would say, are at the forefront, and Indigenous scholars and researchers and communities we should be looking to. And we also believe, and you'll find that today in our handbook as well, that patient and public engagement should be grounded in a social justice and health equity approach. A little bit of a disclosure, because we are accredited by the Royal College of Physicians and Surgeons of Canada, just that I am employed at the George and Fahey Center for Healthcare Innovation as the Patient and Public Engagement Lead. So what are the learning objectives for today? What are we going to learn about? So by the end of the session, attendees should be able to describe the importance of assessing readiness to engage within a research or project team, to discuss the underlying principles of readiness assessment for patient engagement, and be able to use CHI's Readiness to Engage workbook to conduct an internal and external assessment of readiness to engage in a health research project. So let's get into it. First of all, so we are just all on the same page, though we are at an intermediate session. Just want to make sure quickly that we're all on the same page when it comes to what we mean by patient engagement in health research. And so when we're talking about patient engagement in health research, what we're meaning is the engagement of people with lived experience of a health issue, caregivers, families, communities, the meaningful and active involvement of all of these groups in the governance of research. So having people with lived experience on steering committees, operations committees, research teams, the whole gambit. In the priority setting of research, so having communities and people with lived and living experience actually setting the research priorities. The conducting of research, so having people with lived and living experience as co-researchers, helping conduct some of, say, if you're doing qualitative research, a interview or a focus group, and then also in the knowledge translation of research. And another great way of thinking about it is is involving people with lived experience in all research decision making about the research process. So identifying the research priority, helping clarify and define the research question, identifying outcome measures that should be included in the research project, co-designing the methods and the design of the research project, collecting the data, interpreting the research findings, and then in the knowledge translation as well. So just so we're all on the same page, it's not participants, it's partners in research. And quickly, before we start going into the workbook a little bit more, I just wanted to touch on levels of engagement. In our last session, the PE 101 session, we briefly touched on this as well, but just as a reminder that, that patient and public engagement in health research exists on a spectrum with a variety of different levels of engagement or involvement in health research decision making. And so at the very So at the lower end of engagement, we have the consultation level, and that's when you're engaging people with lived experience to receive feedback or input on a research decision. But the research decision-making power still kind of lies with the researchers. So that's why it's seen as kind of the lowest level of engagement. At the collaboration stage, we're looking at actively partnering with patients and members of the public in every aspect of the research process. So this includes the priorities and all of those different areas that I had mentioned before. And so it's seen as an ongoing partnership where decisions about the research process are being shared between researchers and people with lived experience. And then at the very highest level of engagement, that's what we call, a lot of times you'll hear it called user directed or patient and public directed or community directed. But what that really means is that the research itself is being driven by people with lived and living experience. So communities actively control, direct, and manage the research process itself. People with lived experience decide on the issues and the questions that will be looked at, as well as the way the research is designed, planned, and written up. And oftentimes there'll be an advisory or steering committee of community members who will make these decisions. And researchers in this type of engagement play the role of giving advice or even conducting some of the research under the guidance of community members. So that the biggest thing to think about is that people with lived experience hold the decision-making power. Now we get to the good stuff. So how do we prepare for patient and public engagement in health research? More and more what you'll hear is how health researchers have the best of intentions when it comes to patient engagement and see the value of having that experiential knowledge of patients and informal caregivers and communities, but aren't quite sure where to begin. So what you'll find is a growing number of engagement experts and organizations highly recommend that research teams do both an internal and an external assessment of some of the expectations and the willingness to engage in order to better understand at what level your research team is willing to share the decision-making power with people with lived experience of health conditions, among other things. And so what we're going to do is I'm just going to stop sharing for a second and oh, look at that, we can see everyone, and I will bring up this wonderful new workbook that we have. Excellent. So this is our Readiness to Engage workbook, and it can be found on the CHI website, so the Center for Healthcare Innovation website. We can even kind of put a link in the chat box maybe for people who want to connect with it, or you probably already did, Trish, you're always ahead of me. And this is a wonderful workbook that you can fill out. It's a fillable PDF. And it's intended for all research team members, so people with lived experience, as well as health researchers, clinicians, policymakers, and everyone who makes up the research team. And it can be done, questions can be done both individually. So there'll be some questions at the very beginning that you'll be asked to do on your own. And then there are questions to be done together as a team. A lot of the individual stuff is first of all to start critically reflecting on your personal values and your experiences and your interests and beliefs and political commitments around the area of health research that the team is looking at, how these impact the way that you approach research, and how to ensure equity, diversity, inclusion, and safety are being addressed when you're engaging in health research together. And so sometimes I think one of the preambles that we like to say is when you take this book and start and begin to work on it, both at an individual level and as a team, there may be times where some of the reflection and discussion questions will give rise to some feelings and some strong emotions. And for these reasons, we also recommend having some conversations with your team in advance around the development of safe and inclusive spaces so that we feel like we can challenge one another and have some of these more difficult conversations. And one of the recommendations we always have, and you can learn a little bit more on our Knowledge Nudge website, we have a whole section on trauma-informed engagement. But one of the recommendations we have is that you have conversations with your team around what does physical, emotional, psychological, cultural, and spiritual safety look like to me, feel like to me, and mean to me. And so having those conversations, you can start as a group to develop some guiding principles that you can work through together, and kind of a shared language that you can help you have some of these more difficult conversations as well. So this workbook also includes questions for research teams to consider with patient partners and as a group as well. And a number of the questions in the workbook, you might recognize a few of them if you've ever read our 2017 article on incorporating trauma-informed intersectional engagement. But for those who haven't, guess what? This is a nice fillable PDF book that you'll be able to work through as well. So let's start going through it together, because that's the best way to learn how to use things. So we have a little preamble here. One thing we added at the beginning that we thought was really important was some special considerations around online engagement. And a lot of this has been informed over the past year by our collaborative partnership members at CHI. So just thinking about things like sense of belonging, which is a really important one. And with some of the online engagement that's occurred over the pandemic, some feelings of social isolation and disconnection has happened with team members. So it's really important for teams to look at engaging with people with lived experience of health issues to create opportunities to connect and build trusting relationships. And we have some examples in there on how you can do that, whether it's phone calls or reaching out or having weekly lunchtime gatherings where you can share and build a relationship. There's also some pieces
Carolyn,
around. Yes.
Can you just zoom in a bit on the document? I think it might be tough for some folks to read. You can just zoom in on that.
So should I should I do like page?
Yeah,
width?
try page width maybe.
Oh, page width. Sorry about that, guys. Oh, is that better?
I think that should be good.
Does that
looks pretty good.
Let us know in the chat if you're having some difficulty.
Much better. Okay, thanks.
Perfect. So and we also have a mention around safety and confidentiality and accessibility of online engagement with some special considerations around how to make online engagement more meaningful. Now we get to our internal assessment questions, and these are going to be these first questions are going to be some personal questions that we recommend each member of a team to start thinking about and going through on their own before they gather together. So first of all, we want to look at what are my own personal values, experiences, interests, beliefs, and political commitments in the area of health we will be researching. So this is going to be different especially for health researchers who are perhaps more on the quantitative side. On the qualitative side, there are certain methodologies where you do get into positionality and epistemology and ontology and critical reflexive practice. But for some research, this is going to be kind of a new area of thinking about your own personal values and how that relates to the research that you are doing, and some of the political commitments as well. I've had conversations sometimes with researchers who say they don't have a political commitment, and sometimes saying, well, other people have agendas, but it's really important to have some reflexive, some understanding of what those are and how that relates to the health research issue that you're going to take a look at. How do these personal experiences relate to social and structural locations I inhabit? So when I talk about social and structural locations I inhabit, these are socially constructed categories such as gender identity and expression, race, ethnicity, indigeneity, socioeconomic status, age, ability, size, sexual orientation, immigrant status, religion, all of these different social locations in which we inhabit. They're socially constructed and they change over time and space, but it's good to have an understanding of these locations in which you inhabit, but then also going beyond just saying, so perhaps for myself, I could say I'm a white settler, I'm cisgender, and kind of go through the different social locations in which I inhabit. But it's important to also say how these are connected to larger processes of power and oppression. So things like patriarchy, colonialism, racism, capitalism, transphobia, ableism, homophobia, xenophobia, sizeism, and saneism, because this will start to make us think about things like unearned advantages and privileges and unearned disadvantages as well, and how these things relate to the way in which we approach a research subject and approach an area of health research, and how it shapes our values and our perspectives and experiences as well. And this is for both health researchers, but also for people with lived experience as well on the team, because it's important that everyone does this critical reflexive practice. From my perspective, what current health inequities? So when we say health inequities, we mean avoidable and unjust inequalities in health between and within groups of people exist with regard to the area of health in which we will be researching. Sometimes we don't think about this, so we don't think about who has different access to the healthcare service or the program that we're looking at in our health research project, who experiences things differently. And then the important part of starting to begin to think about this is, how are you going to engage those perspectives moving forward? So first, having a deep thought about what health inequities exist in the area that we're looking at, so that we can better ensure that we're going to address it with our research and that we're going to engage these different perspectives. What are my personal values, assumptions, perspectives, and experiences with regard to people living with the health condition that we're going to be researching? And this is good for both health researchers, again, to think about some of their assumptions that they may make about people who live with certain health issues, but also for people who are living, so patient partners as well, to start thinking about how their experience is one of many experiences, and that there may be other partners on your team who have experienced different types of barriers to care, whether systemic racism, whether they've experienced the same health issue in a different way. And so having those thoughts around, what are some of the assumptions that I sometimes make? So if I make an assumption that my experience is similar to everyone else's, as far as health researchers, sometimes thinking about what kind of underlying assumptions have I perhaps made before. And this can also get to conversations around strengths-based and deficit-based. So how we frame health research issues and larger health issues as well. So kind of starting to get at that aspect. We're now going into research teams, so questions that you can discuss as a group. And remember, these are all fillable, so you can put your thoughts and your perspectives and as a group, you can kind of record what your conversation has been about in this area. So to what extent does the team believe that engagement of people with lived experience will improve the outcome of the research and our project? This is really a good heart-to-heart to have amongst your team to really understand where you lie. Do you believe that this can really impact and improve the outcome of the research process, or are you still kind of unsure about it? What is the potential for patient and public partners to influence decision-making within the research process? Again, an important heart-to-heart to have with your team members. Are you open to changing some of your research process or the design of your research project, or adding new outcome measures, shifting the research question a little bit? I guess the next question, how flexible and adaptable is your team going to be if people with lived experience, community partners say, you know what, I think the research should go in a different direction. So having an understanding of this will let you kind of start thinking about which phase and stage of the research process are you truly open to engaging with people with lived experience. And maybe that also means that you're only at the consultation level if you're still feeling like you can't adapt too much. Whereas if you're really, really open, you're going towards the collaboration level of engagement. What is the likelihood the team will fully consider? Again, this is another piece. Like, are we fully going to be open? What if we have suggestions to move in a different direction? How adaptable are we? How open are we to receiving feedback that may challenge some of our thoughts or some of our ideas around the research process? What resources are likely to be available to support people with lived experience in their engagement? So this includes compensation. We're huge on compensating people for their time and their energy and the insight that they bring to the table. But this also could mean having things in place for caregiving, so that allows people to engage, thinking through transportation, parking, food. In the online environment, that might mean figuring out ways for people to engage, whether it's getting tablets for people with lived experience so that they can engage online, having those types of thoughts around what resources are going to be available to help support people. And then what is the research problem we will be looking at? So this is again starting to look at how we have been approaching the research project as a group. So what is how did we decide upon this research question or problem? And so that's really important to start considering. How did we get to this? Did we engage people with lived experience? How did we come up with this? Did we involve people, families, communities with lived experience of this health issue in prioritizing the research area? Is there anyone we have not involved and who should be? So when you have that, those questions above around health equity, have we addressed all of those different barriers? Have we thought about who we need to engage, and are there some voices missing? What assumptions, so beliefs about what causes the health issue we are researching and which populations are most affected, underlie the representation of this health issue? This is really good at starting to challenge ourselves a little bit more. Who do we think is involved in framing and defining the health issue in that way? We don't always think about it. I think probably as health researchers, we often think like this is a very objective process. We identified this question, but really think about as a group, when you're getting together, think about who has been involved in framing and defining the health issue in a certain way. And think about things like um, the pathologization, the medicalization of difference that goes on sometimes within the healthcare system. Think about how things are sometimes framed in a certain way to look at deficit rather than strengths or resilience. So thinking about that is really important. Why do we think why do we think the issue's been framed in a certain way? Um, Sometimes health issues are framed in a certain way by larger systems of power and oppression in order to maintain certain levels of privilege and oppression. So thinking about how is the research issue framed that we're looking at, um, and having kind of some critical thought around that as well. Do we think that the way people look at the health issue has changed over time, historically, or is different depending on where people live geographically? So if we think of certain health issues that have changed over time or geographically, so even we can think about in different countries how substance use is looked at. In Finland, they have much more progressive things around harm reduction, around safe supply and legalization of drugs. The perspective is the perspective around the way the health issue is framed is different. How can we address feasibility and capacity of engagement in this work? This is another really important piece around what kind of supports we need in place to make sure that the engagement is feasible. How do we make room and make time for relationship building when we often have a number of deadlines and things moving quite quickly? How do we put this in? So what are our timelines? So allowing time for meetings where we get to know one another, where we build the relationship, allowing time for partners to process some of the information that they're learning in order to authentically kind of share in the decision-making power. What training do researchers need, perhaps, and team members require in order to fully engage with patient and public partners and community members? So I know some partners in Manitoba are taking some of the Indigenous training, some anti-oppressive, anti-racism training, understanding what types of training the research team might need in order to be able to fully engage with community. Do patient and public partners require training in order to meaningfully engage? So again, thinking about what kinds of training might be helpful for people with lived experience as well. And outside of compensation, what other benefits might we be able to offer partners as far as letters of support or reference, training opportunities, all of these things? How do we think? So this is a tough one, right? We don't think about it a lot. But how do we think the issue of trauma may impact the area of health in which we will be researching? There's a lot of times when we're developing patient engagement strategies, I've had health researchers say, this is not this is not a health issue where we need to use trauma-informed practice. What I always want to recommend to health researchers to think about the fact that people's experiential knowledge that they might be sharing might be intertwined with experiences of trauma. People may have faced systemic barriers, racism within the healthcare system, homophobia within the healthcare system. There are certain practices, if you've had an experience of trauma in the past and then there are practices within the healthcare system that might cause re-traumatization. So even things like just surgical processes and restraints and things like that may trigger people. And so just being open to the idea of thinking through how trauma may have impacted, may impact people who in this area of health, and thinking about how you might be able to address that. Oops. How do we think people with lived experience in this area of health would prefer to be involved, and why? So this is just assessing how your team thinks people would prefer. When we go on to the external assessment, we're going to actually look and ask and talk to people about how they would prefer to be engaged. But this is just to start getting teams thinking about it. What types of challenges or barriers do you think we would need to be addressed in order to make it easier for people living with a health issue, as well as their families and communities, to be involved in research? So when you've thought about the different perspectives that you want to include, thinking about what will help, what kind of barriers you might need to address, and filling that in this section here. For the external assessment questions, again, there are some personal questions to reflect upon individually, and then you move into the group. So external assessment questions on the personal level, we want to think about what are some of the ways in which we can make sure everyone feels safe when working together on this project. So what does physical, psychological, emotional, cultural, spiritual safety mean to me, look like to me, and feel like to me? This is a conversation that I talked about before that we often have as a group, but it's a great way to think about it first on your own, and then you can come together and have that conversation as well. What roles do I think people with lived experience, their families and communities could play and would like to play in conducting the research? Is it sitting on steering committees? Is it operations committees? Is it data safety monitoring, data collection, co-facilitating, co-interviewing? Start thinking about all the possible roles that people might want to play. For patient, public, and community, questions to discuss with community leaders, patient, public, or caregiver partners. So thinking about, is there a history of patient, public, community engagement? So have there been previous research projects done by research team members about this area of health research with community members? And if so, were the outcomes and experiences positive for community members? So understanding what the history has been is really important. Have community members been engaged before by researchers and let down? Has it gone the wrong way? Understanding that previous history is important, because then you can address what kinds of things happened and how you can not do the same thing again. What inequities exist in relation to the health issue being researched? So we talked about that as a group, and now this is having some conversations again around the community aspect. Who is affected differently? So thinking about sex differences on biological, physiological level, but also thinking about socially constructed categories, again, such as socioeconomic status, gender identity and expression, ability, race, ethnicity, religion, immigrant status, size, and sexual orientation. Who has different access to services, programs, and interventions? So think about both geographical barriers and systemic barriers. Where are people at with their health condition? Think about the difference between people who have been newly diagnosed, people who have many years of lived experience, and then people who are in recovery. They all have very different perspectives. Do you want to have all of these different perspectives and engaged? And what are ways, having conversations with community members on what are the best ways to engage these different perspectives is really important as well. Having conversations with people who are living with health issues, so important. How can we ensure diverse perspectives are included? So think about using different participatory approaches in order to meet people where they're at. So there may be a variety of ways to engage people with lived experience, even just on one decision. So you might use an arts-based approach when you're engaging younger people. You might have certain people who are just really interested in sitting at the research table, but thinking about the different participatory approaches that you can use. And we have a neat handbook on different approaches you can use that we can also let you know about as well. Understanding what are the strengths and the values and the skills that individuals and communities have that should be acknowledged and valued. Having those conversations with community and understanding these pieces. And then at the readiness and level of engagement, so we continue to discuss with community leaders, what are patient, public, community partners' values and expectations for engagement? So talking to people with lived experience, what are your values? What are your expectations? What do you want to get out of the research project? What level of engagement? Is it consultation? Is it collaboration? Do you think people with lived experience or community members should be driving the bus? Which level do we want? How would people prefer to be engaged? Is it discussion groups? Do we want to do arts-based stuff? Do we want to do one-on-one conversations or conversation circles, dinners? What is the best way? What types of roles can people play as well? And then working together, how can we become more aware of and take advantage of opportunities where we can challenge one another's ideas and also challenge and renegotiate power imbalances within our project team? This one I like, and I like to say, I think researchers and community partners should have this conversation, but thinking about what does building resilience look like, feel like, and sound like to you? So really taking a strengths-based approach to our engagement and understanding all of the incredible strengths that different community members bring to the table and researchers as well. So when it comes to evaluating engagement, we want to start assessing the impact of engagement. And there's lots of great tools out there about evaluating engagement. These are just some questions within the workbook that might be helpful as you think through this and kind of follow the same line as some of the previous questions when you were preparing to do engagement as well. So how did the way in which people with lived experience, how were involved in the research project help to reduce health inequities? So thinking about those avoidable and unjust inequalities in health between and within groups of people. And you can have this have these questions as a group and discuss this. How did this actually work? How often were there opportunities to challenge ideas and renegotiate power within the team? How were these moments handled? So I think you can probably write some of these answers in there and then have that conversation as well with the team. How did the research team work together to actively define, address, and ensure emotional, psychological, cultural, spiritual, and physical safety for all research team members? So did we do what we set out to do in that pre-assessment? Was there a belief in the primacy of the people, families, and communities with lived experience, as well as in the resilience of individuals and communities to heal and promote recovery? This is a really important one that needs to be considered when you're developing your engagement strategy. Was there an understanding that the experience of trauma may be an aspect that brings us all together and helps to level power differences on the research team? Did the research team understand the importance of differences in power and the way in which certain groups of people historically have not had the same opportunity to voice their concerns as well as the same choices as other groups of people and may have received coercive, disrespectful treatment within the healthcare system? So was there a real understanding of this within the team and within different processes that we engaged in? Did the research team make sure to address historical and present day trauma resulting from colonization, patriarchy, racism, heterosexism, ableism, transphobia, sizeism, ageism, Satanism, xenophobia, and capitalism? Did the research team actively work to dismantle cultural stereotypes and biases? So we're based on all of those different categories. Did the research team leverage the healing value of traditional cultural connections? Were there opportunities to do so? Did the research team incorporate policies and protocols and processes that are responsive to cultural needs? Did the research team have access to cultural and gender responsive support services in case a researcher or a public research partner requires some additional support due to past experiences of trauma? This, I would hope most research teams would have in place, but it's always a good question. So this is, I've gotten to the end of our wonderful workbook. So maybe I'll stop sharing. Oh, if sorry, my mouse pad is not working, so I can't stop sharing. I guess we can open it up. Trish, were there any questions in the chat box?
Yes. So earlier on, Colleen McGavin from BC Support Unit was asking, what has your experience been with using the workbook? So I know we've shared this already with some research teams. What sort of feedback have you had from researchers and or patients in the public who have used it?
For the workbook, definitely we've used it in certain contexts with some research teams. I know the feedback has been that they found it helpful, especially some of the individual questions too, the personal ones, where particularly in research scenarios where you don't typically do that kind of personal level of critical reflexive practice. I think it's helped in kind of letting health researchers especially start thinking about it. And then I know some of the questions around safety as a group, having those questions have really helped to create some guiding principles amongst the group in order to have kind of a shared language and understanding of where everyone's coming from. So in that spot, we've had some successes with the handbook in that regard for sure.
Fantastic. And yeah, I've heard similar things with the few that I've shared it with before we launched it. Just a lot of times it brings up, barriers that they may not have considered, or maybe they didn't consider involving folks at different stages of the health issue that they're researching. So might have just some kind of things that you might not have thought about before, right? That the workbook prompts you to consider. We have Dr. Suresh asking, where or at what level, fun ethics question incoming. Yes. What level does the research ethics committee or scientific committee approval come into play in a patient-centered or patient engagement project? So I was going to share our flow chart, but I don't know if you had anything to mention before I quickly share that.
Actually, I love the idea of putting the flow chart up because that really helps clarify.
Let me just, I have to stop sharing yours.
Yes, if you can stop
here we go. Yeah. Did you want me to speak to it or?
Sure, because I know you've had this question a lot.
Right. So this is adapted from Doria et al. With their permission. They did a paper on focus versus discussion groups and looking at, what is partners versus participants and how do you make that decision, especially in terms of ethics submissions. So we use this flowchart to kind of help research teams think about at which point they may want to involve ethics. So essentially it comes down to whether or not you're collecting data about people with lived experience, written as patients in this flowchart, but we mean people with lived experience. So if you're actually collecting data that you're going to be sharing publicly, that you're going to be reporting on in a peer-reviewed article, it's probably a good idea to get ethics approval. So if you want to publish, if you want to use anything collected in the engagement process as research. Whereas if you are simply bringing people in to make decisions about research, and you might write that up along with a patient partner as a co-author in your paper, that's something where you would want to get people's consent, but you wouldn't necessarily have to go through the entire ethics process. It is kind of a case-by-case basis, but hopefully this flowchart kind of gives you a better idea. I can also share it in the email to registrants as well. And I can't see the chat, so I'm going to stop sharing so I can see the chat. Another question from Saint. How can researchers get support services? What are some ways other teams have tried in the past?
Right. I know we've had some different conversations depending on different communities. So sometimes it might be supports by way of elders in supporting certain communities. Sometimes it might be mental health support. So we've had worked with social workers before that have worked with different people with lived experience who are invited to attend sessions with people with lived experience. Those have kind of been some of the areas in which there's been requests and thought through how we would want to engage people and have those supports in place. We also on our team have somebody with a social work background as well, who has helped out in some of our projects too.
Oh, I think Saint would like to unmute. I still have the permissions on, so I'm going to ask to unmute you. So you should be able to now.
Hi, thanks so much for answering the question, Carolyn. I do have a follow-up in terms of like selecting specific elders or social workers or agencies. I guess, do the research team have an existing relationship with those community resources, or is that something that CHI can help with? Or?
That's a good question. I think as far as elders, I think a great resource would be on Gamazwin to have some conversations around that. Also, there are times where different community groups have specified which elder they would want present. As far as social workers, it's always been a lot around what area of lived experience that people are being engaged in, and whether there is a connection with a social worker at a different community center in which people find are really great at having on the team, and then having conversations, whether they have the time to even be engaged as well. So it's always been kind of on the context of the research project that we've had, but definitely saying we can have some conversations if you want to give me. I think you have given me an email, so I will connect back with you and see whether we can brainstorm some possibilities.
And I think at least across Canada, I would think SPORE support units could definitely be connectors to support services in the community. Okay, and I see Dr. Suresh has their hand up, so I'm going to ask to unmute. So you should be able to unmute yourself. There we go.
Hello.
Hi.
Hi.
Yeah. Okay, so I have a follow-up to the question about the ethics committee approval and so on, because there was a question here regarding how flexible the entire patient engagement project would be. So this is kind of relating to that, because once we I don't know how this is. I'm from India right now, so there's a lot of difference, I believe, between this different systems and the way that a scientific committee or ethics committee generally works across the different countries. But in general, they're not known for their flexibility. I mean, I hope I'm correct in stating something like that. But so when it comes to issues of flexibility with a research project, especially where patient engagement is concerned, how exactly does it work, or does that factor in?
I can definitely speak to this. In our own experience with our research ethics board, and this is at the University of Manitoba, it has been explicitly outlining areas where we intend to have flexibility in our methods and who will be helping make those decisions, how we're going to make those decisions. So we've included like our participatory approach, whether we're going to use a consensus building activity, what kind of things might come out of it, but being very clear that we have to be flexible about these methods to value the voices that we're including as research partners. That has been our way of addressing that in an ethics application. And often it involves, again, like you said, it's different between countries. So I don't know how feasible this is for other ethics board, but we've definitely just updated with amendments as decisions are made with patient and public partners. And, it might take a little more time, but generally, I mean, in our case, they have been responsive. So hopefully that answers your question. Oh, are you unmuted again? Sorry, I'm going to let people unmute themselves because I don't think we have any interlopers.
Yeah, sorry. Okay. Do you mind if I read out the question, because I think that was a
please.
very long question that I forgot. Yeah. Okay. So now, since my area of work, and just to set a context here, is with patients with disabilities, children with disabilities more specifically, and their caregivers. So a lot of these questions are points of discussion for people with a certain or some higher level of awareness than what I've seen with my patients that I'm working with here. So when dealing with communities that have largely neglected discussions on topics like this, they don't really have awareness about these topics, or they, at least from the healthcare perspective, from my perspective, when I've interviewed or had discussions with them, they've been a blank slate in the sense that, a lot of them have come back to me questioning, like, are we allowed to ask questions to you? Sort of, that's the kind of state that they are in. So how can we adapt a workbook like this to have a meaningful engagement or meaningful discussions with patients? That's sort of something that I wanted to know.
No, that's a really good question, because of course, yeah, this workbook could be very overwhelming, I think, at some points of time with different members and what best way to approach. I know one of the ways that we have a lot of times even just started that conversation is through the safety exercise. That's been kind of the number one that we've used with groups, just talking about what does physical, emotional, psychological, spiritual, and cultural safety mean to me, look like to me, and feel like to me. And those questions kind of address that. The idea of safety is different for everyone, and that in coming together and starting to have those conversations is that meeting place where we can start to ask questions, feel more comfortable, and in creating some guiding principles. So people may even say stuff like, well, a safe space may mean like that I can ask you questions and not be judged. Like, is that okay if I do this? And just starting that conversation from there, I found has been one of those universal, like ones that seems to touch people and have them start reflecting in an open way around that. So that might be kind of choosing one or two of those questions to begin with and working with community members.
Yes, thank you. Thank you. That actually makes sense. A lot of sense, actually. Yeah. I mean, once we start the conversation, then, it sort of opens up the floodgates, and then we can keep rolling with it. That's the essence of it, right?
Absolutely. Yeah. Just starts the conversation.
Okay. Thank you. Thank you.
Okay, that was a fantastic review of the workbook. I'm glad it's now out there for folks to use, and you can obviously print it as well if you are more of a hands-on written kind of person. I will send the recording, the link to the evaluation and how to register for the next session in an email to everyone who registered. And speak of our next session, that will be on November 9th, where we'll be focusing on recruiting for patient and public engagement. So important things to consider and some practical advice for what to include if you're going to be advertising for looking for patient and public partners. So thank you all. Everyone take good care of yourselves, and we'll see you next time. Thanks.
Thanks so much, everyone.
Oh, and I do see Paula asking, can you register for all the lunchtime learning sessions at once? Unfortunately, no, just because the content is so different and Eventbrite doesn't give us the option to make them individual, but I'll keep sending emails to everyone so they're aware of the sessions. All right. Thanks. Bye.
Thanks.